Hey everybody, welcome to another video. This time we're going to be talking about liver function tests. Before I say anything, yes, I know, ABG's part 2, it's on its way. I haven't forgotten about it. I just thought this was a really important topic because we don't really get a lot of exposure on how to read LFTs, even though they're such a key part of training in medical school and then becoming a doctor as well. So I figured, let me make this video so then that way I can get this off my conscience as well, which is very full at the moment. Anyway, enough about me. Before I continue, here's a small key. You're going to be seeing a lot of different letters put together, but this is what these letters mean. 4 of those combinations are just enzymes: ALT, AST, ALP, GGT. They're all just enzymes, and then the last two, INR and PT, they're a way of measuring clotting, which we'll get into later. Okay, so let's get into the word liver function test. So what are we testing? Well, we're testing the liver. there's nothing else to be said except, yeah, we're testing the liver. So what is the liver? Well, it's an organ in the body which does way too many different jobs for one organ to handle. So what does it do, and what do we need to know about the liver to understand liver function tests? Well, to understand any part of the body, we need to understand two things. The anatomy and the physiology. It always boils down to these two parts. Okay, so what is the anatomy that we're testing? Well, we've got two different things I want us to be worried about in the liver. So when you take a liver and you break it down into its histological form, you're going to reach what's called the hepatic lobule. These are communities of different cells and vessels which form the functional unit of the liver, which means this is where the magic happens and this is where the damage happens as well. Now, there's many things that can happen in the liver, but for our LFTs, we want to be focusing on the bile duct and we want to be focusing on the hepatocytes. Why? Well, I'll explain. So the bile duct is a tube at the end of the day. And what happens to tubes when they go wrong? Well, many things can happen, but in this case, these get blocked. They either get blocked from the outside or they get blocked from the inside. But regardless, they get blocked. So this is what can happen with the bile duct. With the hepatocytes, well, these can essentially be killed. They are lost in battle of trying to keep the body alive, and we call this either hepatocyte death, or they get injured, or hepatocyte injury. So with these two things in mind, this is how the anatomy can be affected. And we're going to look at how the body fires these alarms at us and how we can use LFTs to read the alarms. The first thing I want us to remember is, how can we tell which enzymes are going to show us hepatocellular injury? Unfortunately, there's no way to really make sense of it unless you go very deep into the physiology. But I've created a meme, and in my mind, that's all that matters. So with this meme, it's kind of just remembering that the letters A and T, the enzyme has the letters A and T, that means that it's pointing towards hepatocellular injury. And which enzymes have A and T in their abbreviations? ALT and AST. Both ALT and AST show hepatocellular injury. And these two come together when the liver cells get affected. So now that we know this, what can cause it? And specifically, what's going to make ALT and AST rise to show a hepatocellular injury? What can cause the body to essentially lose liver cells? So have a pause, have a think, and try to think about what can cause liver cells to be killed. Okay, so let's go through the first one together. There are many different possible answers, but I've managed to think of four. So here comes the first one. Alcohol. So, what does alcohol do, very briefly? When your body is trying to, when you consume large amounts of alcohol, and I mean large amounts, but it can be any amount actually, the body converts alcohol into acetaldehyde, which eventually gets converted into aldehyde. Now this chemical is safe. Why is it safe? Because your liver, well, it's processing acetaldehyde, but the problem is, well, acetaldehyde is very toxic. And so what happens is your body stays safe because of your liver, but your liver takes a lot of beating in the process. And that beating is in the form of your liver cells essentially dying from processing the alcohol into acetaldehyde. So this is why we see a lot of patients who have liver damage often have a very high drinking history. Not guaranteed, but there's a strong connection. Okay, so the next reason and the next cause I can think of, and this is seen a lot in emergencies, is paracetamol overdosing. So, paracetamol overdosing is one of those things you see a lot in emergencies, and they are often caused because of either accidental reasons, so people don't know how much to take, or uh, because of metabolic reasons, so people's bodies process paracetamol faster and more aggressively than they should, or unfortunately on intention with people trying to harm themselves. Now, with paracetamol in large quantities, as opposed to alcohol, which can be at any quantity, can be processed into a long worded compound called NAPK. Now, NAPK is processed in the liver, and the issue here is, like the acetaldehyde, is that NAPK is very toxic. So again, in an effort to save your body, your liver ends up doing a lot of the processing, but hurts itself in the process. Okay, and the next one that I'm thinking of is liver inflammation. Specifically, I'm thinking about all forms of hepatitis. So we've got viral hepatitis, which are hepatitis A to E, autoimmune, and drug-induced. But there are many other examples, and there are many, and almost all of them can cause this. And the final thing I'm thinking of is liver cirrhosis. Essentially, when all of these things become way too long in time, so essentially chronic, you'll eventually get liver cirrhosis. So many different causes coming together, causing liver damage, you'll get liver cirrhosis eventually. Alright, fantastic. So now we've covered the different causes of what might result in hepatocellular damage and hepatocellular injury. But as we were explaining, there is not just a end up happening is that the tubes can get blocked. And so what ends up happening as a result is the body will not be able to use the bile that the liver and gallbladder store to break down proteins and fats that we need to digest. And so what we can understand this is from these two tests that we haven't talked about yet, which is ALP and GGT. So I always get concerned about the difference between the two because they seem like they do the same thing, but they don't. And this is explained on screen. The ALP, this is responsible for saying that something in the body is wrong. It's not necessary that it has to be the liver. So, for example, ALP can be raised in Paget's disease of bone, but not GGT, because there's no issue with the liver itself, but certain MSK orthopedic issues can cause a rise in the ALP as well. So the way I like to remember this is ALP kind of reminds me of the Alps. So we have a picture here of the Alps. And so the Alps is a big mountain range. It's got a bunch of different mountains all put together. And so I like to think of these mountains as sort of all the different problems that it could be. So, for example, it could be Paget's, it could be a hepatic problem, it could be a gallbladder obstruction, it could be a rheumatological problem. So it could be many things. So the Alps are sort of a wide range of different possibilities of what could be going wrong with the body. But there's another way to help us narrow it down. So to do this, we use what's called GGT. So the way I like to remember it, because I play a lot of video games, is if you're asking yourself which part of the body is affected, GG's, guys, it's the liver. Game over. It's the liver. We know it now because the GGT would be raised. So GGT is specific to the liver and the liver only. So it helps us rule out if this is a hepatic cause or if this is a cause for other parts of the body. So that's why I've written that it can help rule out bone problems as well. Cool, so now your LFTs have demonstrated that there's potentially a obstruction, or what we like to call a cholestasis. So if you break down the word cholestasis, really just means bile for chole, and then stasis just means something's not moving. So when the bile is stagnant or it's not moving or it's static, what we say is this is cholestasis, and it's generally caused because of an obstruction. So the obstruction of this bile can either be inside of the system or inside of the liver, or it can be outside of the liver. It could be something that has nothing to do with the liver's function, or it could be something to do with the liver, but it's not inside the liver itself. So that's why we have intrahepatic for inside the liver and extrahepatic for outside the liver. If it's intrahepatic, you've got things which can happen inside the liver, which causes the bile ducts to get shrinked and closed in on. So you've got things like hepatitis causing inflammation around the bile ducts to constrict the bile duct. You've got cirrhosis, which is literally scarring of the liver, and you've got malignancy pressing down inside of the ducts themselves. And then you've got extrahepatic, which involves any malignancy pressing down on the bile ducts. PSC, which is primary sclerosing cholangitis, an image which can be seen here. So essentially the bile duct itself gets squeezed in on, essentially preventing bile from exiting the gallbladder. And then you've got primary biliary cholangitis as well. Okay, so we've explained ALP, ALT, GGT, and AST. So we've explained all causes of hepatocellular damage, and we've explained cholestasis. Now the next part is understanding bilirubin. So bilirubin is pretty straightforward, but we should quickly just understand the physiology at play here. So imagine we have a red blood cell and it dies. So what ends up happening is the red blood cell is carrying what's called hemoglobin, which can be broken down into two parts, heme and globin. We don't really care about the globin part, it goes on to do its own thing. But what we do care about is the heme. the heme ends up getting converted into what's called biliverdin in the blood. That biliverdin is sent into the liver, and it's classified as what we call unconjugated bilirubin, until an enzyme called UGT1A1 ends up converting that bilirubin into conjugated bilirubin. This bilirubin is sent into the duodenum, where it's processed into urobilinogen. Most of it goes into the rest of the body, but some of it ends up staying back and gets reabsorbed in the kidneys. And this is the distinct chemical and the distinct substance that gives poop its brown color and gives urine its yellow color. So this is why we often see people with liver damage who have a raised bilirubin in their blood end up having pale colored stools or dark colored urine. And so we can see this on the blood test in the form of a raised bilirubin, and often we can conjugate or have unconjugated raised bilirubin. When we talk about conjugated raised bilirubin, we're talking about things which are happening post-hepatically. So, for example, to understand what that means, all forms of bilirubin which are raised can be explained in three ways. We can say that it is prehepatic, which means the damage starts before it reaches the liver. We can say that it's hepatic, which means the damage happens once it's inside the liver. And then we can have post-hepatic, which is when the damage happens after it's processed by the liver. Prehepatic, hepatic, and post-hepatic raised bilirubin, which we also refer to as jaundice. And we refer to it as jaundice because what we find is when this bilirubin is not put in the right system and it stays in the blood, it gets deposited into the skin and into the eyes, resulting in a patient appearing more yellow. So what ends up happening is this conjugated bilirubin is not able to be processed properly either in the liver, or it's not being deposited into the system properly. Thus, as a result, that conjugated bilirubin, which we have managed to successfully convert, ends up getting deposited in the skin. You can also have what's called unconjugated bilirubin, where the problem is either inside the liver or it's before the liver is even involved in the first place. So we call this prehepatic raised bilirubin, or prehepatic jaundice. And this is shown, and this can be further analyzed if we check for causes of hemolysis. So things like a full blood count, reticulocytes, LDH, and haptoglobin. And then you've got Gilbert syndrome, which is a disease where there is an autosomal recessive mutation of the UGT1A1 enzyme, non-life-threatening cause of jaundice, which essentially it just causes occasional jaundice and doesn't require any treatment except waiting and watching. Okay, so we're on the final stretch. What we need to understand are the last two, which are the enzymes produced by the body to help with maintaining the protein density in the blood, and it is responsible for clotting. So when we have albumin and clotting factors, which are responsible for clotting in the blood. And so what we have is albumin. When it is decreased because of liver damage, we can actually use it as a means of telling us if there has been long-term liver damage. Because albumin has a raised half-life, what ends up happening is we can see that unless or until there has been long-term damage, we will not be able to have a decrease in albumin. When there is a decrease in albumin, this can either be because of abnormal LFTs. This can be shown in abnormal LFTs, but it can also be shown in normal LFTs as well. So if you've got normal LFTs, you've got non-hepatic causes, which are essentially things that have nothing to do with the liver. Malnutrition, protein-losing enteropathy, sepsis, and nephrotic syndrome. But if you've got bad LFTs, then this can be a sign of chronic liver disease, or a really bad dysfunction. What's more, we've got the clotting factors on the other side. So one thing you need to understand is that clotting factors have a short half-life. They are meant to be used almost as soon as they are ready to be produced. So as a result, when you've got really bad clotting factors, you can get acute changes, which means that there are fast problems happening in the liver. So as a result, we like to measure both the PT and INR as a means of checking if all of the enzymes which are vitamin K dependent, i.e. enzymes 2, 5, 7, and 9, are affected by the liver damage. And so we can see this being affected in the form of the PT being affected. And then the INR is another way of essentially introducing the possibility of vitamin K enzyme damage. And so when you put this understanding together, what you'll find is that PT and INR are often raised when there's vitamin K damage. Okay, so just to summarize, this is the final slide and the final thing I want to show. So if you haven't been paying attention at all in this video, please pay attention to this part. So we have essentially a very quick summary. So ALT and AST show hepatocellular damage, ALP and GGT with show indications of obstruction. Both PT, INR, and albumin are synthetic function tests, but one is more short-term and one is more long-term. And then bilirubin itself can be broken down into conjugated and unconjugated bilirubin, and depending on which one is raised, can also show different pathologies. One more thing which is extremely important for your clinical practice, which is you can never rely on an LFT by itself, and they are very rarely diagnostic. You need to rely on it as a tool to help you, along with clinical information and other tests and imaging, to come to a final diagnosis. Never use LFTs alone as a diagnosis. Thank you.